Thank you, everyone. So now I'll introduce Dr. Elisabeth Wilde, who's moderating the next session.
Hi, it's my great pleasure to introduce our first speaker, Deleene Menefee. And Deleene obtained her graduate psychology degree from the University of Houston and completed her postdoctoral or predoctoral internship at the Michael E. DeBakey VA Medical Center. She joined the faculty at the DeBakey VA in August of 2008 after completing a postdoctoral fellowship in serious mental illness. Dr. Menefee is a practicing Texas licensed psychologist and currently the Women Veterans Program Manager at the Houston VA. She has extensive experience providing trauma-informed mental health services to veterans of all eras, but has a strong passion for equitable services for women veterans. In addition to her academic appointment as an assistant professor at Baylor College of Medicine, Dr. Menefee also serves the Houston site lead for the Women's Health Practice-Based Research Network. Her areas of research include PTSD from military-related trauma and interpersonal violence, examining reintegration issues with returning veterans, trauma-informed treatment, and treatment outcomes that inform best practices for the unique mental health needs of women veterans. Deleene is a terrific colleague and friend, and I'm so excited to hear her talk.
Thank you so much. I really appreciate that. It's my pleasure to be here, and this has just been an amazing conference already. I'm just thrilled with everything that I've heard about today. I'm going to share my screen. I have just a little bit of information to talk about today. And what I'm most excited about is so much of what I've heard today is I'm hoping will be, in my presentation, will be validating and also supportive of so many of the things that we've already heard. Of course, I work for the Department of Veterans Affairs. Before I say anything further, I just want to make sure that everyone understands that these views are mine. It's just my opinion, my research, my understanding, and these do not necessarily reflect the position or policy of the U.S. Department of Veterans Affairs or the U.S. government. And I just want to make sure everybody can see my screen. Am I sharing okay?
You're good. Thank you.
Thank you so much. So I'm so thrilled to be among this group of experts and passionate advocates. It's just been a really meaningful day for me already. So my goal is to talk just a little bit about who the United States women veterans are and describe the intimate partner violence prevalence and clinical concerns among them. I'm going to be coming from this as a licensed psychologist and also as a person who, as the Women Veterans Program Manager, advocates a lot for our women veterans. Today, I'm hoping to identify just a little bit of how we use different IPV tools in VA, and also to kind of expand on what Dr. Dams O'Connor was speaking about in terms of trauma and violence-informed care from a health equity perspective. It has only been in the last few years that the VA has developed what they call an intimate partner violence assistance program. And they did this because of the very strong public health concern that is becoming more and more apparent. A few years ago, I was fortunate enough to be on a study where we looked at why so many veterans, especially those coming back from Iraq or Afghanistan wars, were, being arrested and having all of these problems. And there was all this discussion about aggression. And one of the things that we found in that study by Andrea Teton is that impulsive aggression over any other kind of aggression is what tends to lead to not only exacerbations in PTSD, but also some of the anger problems that we see in a lot of our returning vets. And that, for me, really started this whole process of, wait a minute, what about all of the things that are happening with intimate partner violence? Because none of these things happen in isolation. So first, I always like to take a step back and ask, who is today's woman vet? Now, this picture here is just, I love it because this is from the U.S. World War I. This was in 1918. These are Marine reservists who have volunteered as nurses to go somewhere into Europe and do whatever it is that they do. And you can see there, these ladies have volunteered. At the time, they were given no benefits when they were released. They were never acknowledged in any way for their service. And so today, we still have a lot of people, when they think about women in the military, they think about nurses, secretaries, people doing timekeeping, making sure everybody gets paid. And they maybe even don't even see women as leaders or admirals or generals or any of those kinds of things. And yet we have tons of them. So I'm going to spend just a little bit talking about who women veterans are in the United States. Now, up until about a year ago, maybe a year and a half ago, this President Lincoln's quote used to say, to fulfill the promise to care for those who have borne the battle and for their women and children, or wives and children, I think. And so that has just recently, within like the last year and a half, been updated because women have always served in the military, not only in the US, but most everywhere. Women have always served. And so kind of getting a different perspective and understanding that these women are not just secretaries or nurses, but today's U.S. women veterans are actually in every single aspect of military service, including combat roles. And for lots of years, we've had women in combat roles who that is not their official military operations specialty, but because of skills or circumstances, they found themselves in positions where they were actually fulfilling a combat role. So when these women leave the military, they're coming in and now taking up about 15% of our VA patients. And I want you to understand that this 15%, it only represents about a 41% penetration in the market for VA. In my area, I have 21,000 women veterans that our area serves. But if that's only 40%, that means I've got another 40,000 women out there who are not using VA services. And I want to make that point a couple of times today. So the interesting thing about our women veterans is that they are a lot younger than our male veterans. The men who come to VA for healthcare services, 72% of them are over the age of 55, and the mean age, depending on which city you go to, is somewhere around 65. So when you come to VA, it's typically an old man's environment. Well, the problem is that 70% of our women veterans are actually younger than the age of 55. At my facility, the average age is 41. So you can imagine, like our primary care docs, our mental health specialists, all these different people, they're really seeing two very distinct populations, one with reproductive health needs and all kinds of other things, and one with geriatric aging, long-term chronic pain issues. The other interesting thing is that, unlike our male veterans, our women veterans, 43% of them belong to a racial or ethnic minority. So we're getting a lot of diversity of experience, diversity of background, and nearly half of them already have a college degree. Many of them are coming out as officers. And interestingly enough, many of them are serving 20 to 30 years before retiring and coming out as veterans. So VA has had to take a big step back and kind of a wake-up call and say, wow, we need to be more available to our veterans and to have services that are specific for them. And unfortunately, women who are veterans oftentimes feel invisible. I'll never forget, I was pretty young at VA, about 17 or 18 years ago, and I heard a woman veteran say to somebody else, "Don't thank him. He's not the veteran. I'm the veteran." And this is still something that happens today. It wasn't that long ago that I got called down to the security area because there was a woman who was really upset at our VA. She was demanding to speak to someone because she tried to valet park, and the valet person kept saying, "No, this is for veterans. Where's your veteran?" And she kept saying, "I am the veteran." And then she got very upset. But unfortunately, we have a lot of women who are out in the community who never are asked whether or not they're a veteran. So they may have all of these experiences we're about to talk about that no one ever screens them for. And I do have a link here called She Wears the Boots, which is a really interesting podcast for women veterans, but I listen to it as both a provider and an advocate, and I learn a lot from it. So I want to show you some pictures of what today's woman veteran looks like. So the first thing I want you to notice, these are all Iraq and Afghani deployed women who are either in the Army in the green or who are Marines here. And this is just showing them in their day-to-day activities. And what most people don't realize is that if you're a woman in the military, you're packing the same 50 to 60 pounds of gear that men are. You are being exposed to the same potential improvised explosive devices or vehicle-bound IEDs that the men are. In these particular wars in Iraq and Afghanistan, and then in either other places that we call conflicts like Bosnia and places in Africa, etc., there are no front lines. There's no sense of going out into the jungle and fighting and then retreating back to a safe area. So even if you're like a truck driver who's driving dog food out to a forward operating base, you are still exposed out in the desert or in the mountains the same way all of the other combat folks are. A couple of things about these next few slides that I just want to bring your attention to is that, you know, a lot of our folks these days, we're not fighting in jungles anymore. We're fighting urban warfare. We're fighting in places where children are. We're fighting in places where people are just trying to live and do business and those kinds of things. So there's a tremendous amount of emotional toll on all of our military personnel. If you look at the top left corner, I want you to imagine that Marine who is sitting up with the helmet on, I want you to ask yourself, what would happen if she got her period? These are women who are 18 to 45 years of age. What would happen if, because of these conditions, all of a sudden she stopped menstruating and went months without it? You know, wearing 60 pounds of gear, doing 10-mile hikes. If you're not mounted, meaning you're not riding in a truck, you're unmounted, you're walking. All of that strenuous activity can really interrupt someone's system. So there are a lot of things that we don't think about when we think about what women endure in the military. Now, there are a lot of things that we know, and unfortunately our government calls collateral duty and our collateral damages, which is a term I don't personally care for. But it's the idea that we know when we go to war, we're going to lose people, they're going to die, we're going to lose property, et cetera, et cetera. But one of the collateral damages that we should never have to face is the level of gender-based violence that occurs in the military. So if you are, and I'll never forget, y'all, when I first started this way back in the day, I was so excited because I wanted to work with military sexual trauma, and I'd gone to a dermatologist, you know, just to get skin checks and stuff. And I was bragging about what I was doing. And he said to me, well, I just can't believe that our barriers are so bad that people can get in and rape our women. And it took me a moment of stunned to realize that he did not understand that military sexual trauma means being raped, harassed, whatever, within your command, within your base, within your unit. It doesn't mean that the enemy is coming over and doing this to you. And unfortunately, so I'm like in my 60s, and here's what I want you to consider is that, let's say I live to be 80, 85. I have about a 20 to 25% chance of being raped in my lifetime. However, if you're a woman in the military and you serve even 4 years, you're twice as likely to be raped by a fellow service member or officer than a civilian woman like me across my entire lifespan. So in a very short period of time, you can see all of the things that are impinging on a woman military personnel's mental and physical health. Now, unfortunately, another thing about MST that I I often hear, I'll hear people say, oh, I have MST. Well, much like IPV, MST is not a diagnosis, it's a past experience. So what makes military sexual trauma worthy of a discussion during intimate partner violence? Well, military sexual trauma is very intimate and it is often interpersonal, mostly because it's committed by someone who is known to the veteran or to the military personnel. It is not someone who's an enemy or down at the bar or whatever. It's frequently like incest or date rape, in that this is a trusted other who is committing these crimes. And it has a lot of connotations. Let's say it's your commanding officer and you're assaulted by this person, and then the next morning you have to go stand in formation to get your duty from that individual. So this person that you've trusted has violated you, and because of the way that the system is in the military and the hierarchical patriarchy, there is no other way. I thought I had turned that off, sorry. There is a lot of times no recourse for reporting. There's nothing that can be done. And what people tend to not realize is that, and in a study that we're currently trying to publish, what we found is that, sexual assault is very violent. One of the first women that I worked with was very, very strong. She was actually fully armed when she was attacked by her fellow service member. She wasn't, drunk or any of those things that she could easily be overtaken, other than she was surprised. She fought. He beat her in the head. I don't mean to be traumatic, but he did hit her in the head with his gun a number of times until she lost consciousness. And people tend not to equate sexual assault by intimate partners or by these kinds of situations with severe brain injury. And in our study, we found that almost 22% of people with military sexual trauma had been knocked unconscious. And I think it was upwards of 30% had been assaulted with a weapon. So in my work and a lot of what I promote, I really want to talk about trauma sensitivity and being trauma informed. Because we know that there's this really critical role that trauma plays in the women veterans that we see. The majority of them not only have military sexual trauma, potential blast injury, or some kind of vehicular accident, but also many of them have adverse childhood experiences where, even though it might not be CTE, as we just learned, the cumulative trauma can have all of those axonal injuries and all kinds of other things that are impacting someone before they even get into the military. Then let's say that they have military sexual trauma. Well, they're 1.6 more times likely to have later intimate partner violent relationships if they have a history of MST. In fact, we know that the prevalence is greater. The IPV prevalence is greater among U.S. women veterans than it is among U.S. civilians. Consequently, we need to have, as everyone today has talked about, trauma-informed care that is grounded in the belief that no matter what a person is coming in for, no matter what stage that they're at, that we need to have a trauma-informed mindset, and people need to be trained in the neurobiology of trauma responses. I work with a lot of primary care veterans who get primary care doctors who are frequently asking me, well, why? I just want to do a physical exam. Why is this person so jumpy? Why did they say that I was, too aggressive, or all of these other things? Because they're not looking at this person from a trauma-informed lens. So the patient's behavior looks to them like they're being resistant or non-compliant. Which are two words that I don't personally like those either very much, because I don't think it has anything to do with being resistant. It has to do with being in survival mode. So I love this model from the World Health Organization that just talks about, part of being a trauma-informed of a trauma-informed mindset is understanding that nothing occurs in a vacuum. And so much of our treatment from a mental health perspective and even from a physical health perspective is focused on the individual. And yes, we need to get the individual safe. We need to get them health care, all of those kinds of things. But they exist inside of many relationships. I loved hearing about Nikki's work on community violence and understanding society. And what I want to bring to the table today is understanding the military ecology. So when you join the military in the United States, you are stripped of everything. Ever wonder why they shave their heads bald and take everything away? When my son went in the military, I got a box with his belongings in it. He literally had nothing left but what the military gave him after he went to basic training. And they do that so that they're stripping down that idea of you as an individual in society. You now basically you belong, you are GI, government issued soldier or sailor or whatever. That's what GI means, government issued. So you now are in a relationship with the United States military, and your community is the military. Your society is whatever your command has going on for you. And that is where there's so much patriarchy and so much of a power differential that is kind of a breeding ground for a lot of this gender-based violence. So let me just make sure I'm doing okay on time. Okay. So trauma-informed care for veterans, this is something that I think is very helpful. And if this is a repeat for something you already know, then just think of it as a validation for how well you're already doing. But given the fact that we know that veterans have such a history of trauma, we need to assume that any veteran that's coming into our doors has a trauma history. It's just easier. It's easier because we know that so many of them do. And to adopt that standpoint as a universal precaution. And what I want to say also is that if you are in the community and you're seeing women, ask them if they've ever served in the military. And I think you're going to be surprised at the number who actually have. So the guiding principles of TIC are basically things that we all already know. This could be Maslow's hierarchy. This could be any number of other principles. People have to have safety first. So if you are seeing them as a community provider, safety is the most important thing. And I included a trauma care checklist that I give to primary care providers. And to radiologists and to MRI technicians, because think of how many times, if you're in any of those roles, you've just like barely knocked on the door and pushed it open. How many times have you just walked in with a paper in your hand and you're not even seeing that person who's sitting on the MRI table or wherever that they are? All of those kinds of things can be really triggering and induce fear. So we will always want to knock and wait before entering. We always want to tell people why we are giving them an assessment, why we are asking these questions. When someone signs up for a research study and they know that they're going to be asked these kinds of things, that's very different than going in for a cough and cold or going in because you're depressed and someone's now asking you whether or not you've ever been hurt. Giving people a reason builds on this trustworthiness. Also, the other thing that I've seen happen and have actually experienced is I've had someone, a nurse in a exam room, give me a gown and tell me to get undressed before I've even ever met the doctor. That is not acceptable. From a trauma-informed care perspective, we want to meet people, we want to look at them in the eye, we want to be equal with them, we want to establish collaboration and mutual goals, and that engenders respect and trust. Also, people have to have the option of where they want to sit. Now, I'm really bad at this because of all these years of harping on this. I went to my doctor. I don't go sit on that table. I go sit over in the chair. When it's time for the physical exam, I'll go sit on the table. But until then, I'm sitting in the chair. And that may be just my way of having some control over a situation that feels really out of control to me a lot of times. And I want to just kind of end this up with this thought. A lot of us are not taught, as our very first keynote speaker said, we're not taught how to deal with these things. We're not taught how to ask these questions. So I provide a little opening statement here that I use frequently. And I use the word we a lot, kind of the queen's we. We know that many people have experienced significant traumas in their lifetime, and sometimes those traumas can affect your health, not just your mental health or not just your whatever it is. And since I'm your provider, I want you to know I routinely ask all of my patients about their history of trauma because it matters. Have you experienced any of this? And if they don't know what a trauma is, you can define that very easily by just saying something that's happened that's unexpected, that was shocking and horrific and changed your life. It could be anything from a car accident on. Language matters. I've heard that several times today. Language matters. And I want to give some examples, and I've heard a lot of examples already today. There are ways that we communicate with people that can really invalidate, undermine, and stigmatize them. Crimes of passion. That is the one that really, if anything is going to set my hackles up, it's that one. These are not crimes of passion. When we're dealing with people who've experienced intimate partner violence, we need to use those words, which is one of the reasons why we really recommend not to use perpetrator, abuser, any of those things. We want to have neutralizing language. This person used violence against you, not this person has anger issues or whatever, but this is a person who uses violence. This is a person who uses violence when they become upset. And another thing is kind of getting back to that example that we used earlier about how, people say, oh, well, he did that because he's a veteran. PTSD causes anger issues. Well, the reality is that there are lots of people with anger issues. That doesn't mean that they're violent. I felt angrier earlier today and nothing got broken, damaged, and no one was hurt. Anger is a normal human emotion. So when we call it anger issues, we're actually minimizing. Now, personally, I fought for the word perpetrator and offender for a long time. I didn't want to give those words up because I never want to minimize the fact that this is a crime. An assault against another human being is a crime. It doesn't matter who they are, what they've done. It is not acceptable. And so this has been a big change for me to say uses violence instead of perpetrator. So that's my own anger issues I have to deal with. And being person focused is not always the best idea either. When someone behaves abusively towards you, that is what we want to focus on, is that behavior, not on whether or not. And this works both ways, because how many times, not only in sexual assault, but in other areas, we ask people, were you drinking? Were drugs involved? What did you do? What did he do? That is not the point. The point is that violence towards another person is not acceptable. It is harmful, it is hurtful, and it has lasting long-term consequences. I also want to talk a bit about victim blaming, and I know I'm preaching to the choir, but why didn't you just leave, or why did you wait so long to leave? As a clinician, way back in the day, learning how to be a therapist, one of my very first mentors told me that the question, why now, was going to be so powerful for me. So like if people come into therapy, you ask them, well, why now? Because people don't come to therapy the first time something happens or goes wrong. They usually, have a lot of stuff happen. They've been depressed for a while, et cetera, et cetera. So what we want to do is a lot of times ask them, well, why now? But why now is not the point. People have their reasons to stay. And relationships are complex, and these situations are complex. And given everything from reproductive health coercion, financial coercion, employment restrictions, all of these different things, you know, the idea of leaving is just so, it's just not often possible. Plus, as my elders used to say, sometimes we just get the sense beat out of us, literally, you know, from a cognitive perspective, the idea of even organizing how to leave is just too overwhelming. So we want to be validating. So the last thing here is ignoring the likelihood of brain injury. And I loved how our first keynote speaker talked about that. You know, we all know that you're getting hit right here. And I'll never forget, Dr. Wilde is the one who first taught me about the prefrontal orbital area and executive functioning. And I remember thinking, wow, how many times have you know, women in violent relationships been hit in the eye, in the head? Another one that really bothers me a lot is oh, he was just trying to choke me out because I was really upset. I've heard that one a lot. And that one is just not okay either. So we need to educate patients that, you know, choking somebody out because they're upset it's not the only option. There are other ways. And then acknowledging also that getting hit in the head can make it difficult. I want to talk am I still doing okay on time? I think so. Carrie? Okay.
You are good. Sorry, I was trying to
Okay.
unmute.
Thank you.
You're welcome.
So there are some considerations as a clinician for documenting, and I'm not going to go over all of these, but I want to talk about a trauma-informed approach to documentation and realizing that there are several factors we need to be really aware of. Now, I don't know about all of you guys, but veterans love to access their veteran records. And we have a lot of veterans who are married to other veterans and who try to access each other's records. So we always want to make sure that we are using first person language and we're not using any of those labels we talked about earlier. And that you always get consent for any kind of documentation. I think as clinicians, a lot of us know that we say the veteran states or reports, the patient said, and we try to not editorialize our own opinions in there. I also try to never use the terms IPV or domestic violence in VA. Our IPV AP coordinator, her note documentation is on something with a title called Healthy Relationships or Relationship Safety. It never has anything in there about her as the intimate partner violence coordinator or anything like that. Just because we know how controlling and coercive some of the users of violence can be. So we just need to be mindful of that. If you're doing an assessment and a safety plan, in VA, we're required to put safety plans for suicide into the medical record, but we never want to put a safety plan about IPV in the medical record. Okay. So I'm not going to spend a whole lot of time on this. This is just VA's first you guys are going to meet Kate Iverson in the morning, and she really spearheaded this. This is taking the e-hits and putting it into a way that we can talk about it in VA. So you will recognize all of these items here and the ability to indicate over the past 12 months how often these things have happened to you. And if any of these things are endorsed, then we want to go on to a secondary risk assessment. And the secondary risk assessment is really important because this is where we get into trying to understand frequency and severity. And for psychologists, that's really what we want to know about a lot. We want to know how frequent, how severe it's getting, has it gotten worse? And especially with a patient that I just worked with who was pregnant, and who we know that when people are pregnant, that IPV tends to escalate. So we want to know about that in the past 6 months. The one that I think needs to be added is about stalking. We include stalking in the definition of IPV, but we very rarely screen for that. I'm not going to spend a whole lot of time on safety planning. Safety planning is something that people who are advocates at shelters, this is something that a social worker would probably do, because I do want to talk more about the actual therapy. So there are evidence-based mental health clinical approaches for the treatment of PTSD and depression, which are secondary to intimate partner violence. And I've heard several people today say, don't assume mental health is the priority or is even a diagnostic criteria for someone. Most people have to get safe, they have to get established, they have to get their kids fixed up, they have to get in, whatever it is they're going to be doing with their life. And the idea of talking about the trauma they've endured is just unreasonable. And I want to talk about these just very quickly. There are all kinds of articles and online stuff to look at. I want to talk about the theory and what's expected. Cognitive processing therapy is this idea that you take someone's trauma and you help them look at it in a way that helps them to stop blaming themselves, stop having negative feelings towards the world and other people, that helps kind of reconstruct their idea of what happened. So if they're blaming themselves, I should have made better lace on his fried eggs, for example. That you're helping them to see that those things are not really the reason that the trauma happened. Now, this does require people to write a written trauma account of the worst traumatic experience. We're calling that the index trauma in CPT. Well, everyone on this call knows that there is often many, 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 many worst events in IPV. So asking someone to pick one is often very difficult. And the second thing is that it requires a lot. You have to do a written account of what happened. There are worksheets. This can be done in group or individual for 90 minutes. There's just a whole lot to it. Prolonged exposure therapy is emotional processing therapy. So your idea here is that you go back and you pretend like it's happening in real time. You close your eyes, you're saying, and I was standing at the stove and I'm frying the eggs and I can smell the grease, and all of a sudden I hear him. So you're actually in the moment. And for a lot of people, this is really difficult, and it takes a long time for them to be able to get there. So the idea is that you habituate, you instead of desensitize, which is the next one, you're habituating to a recalibration of threat appraisal. So, for example, in vivo exposure therapy, if someone, like part of your past is someone walking up behind you and harming you, having someone walk up behind you now is going to trigger anxiety, panic, your threat appraisal is going to be out of whack. So what we want to do is to help people regulate their emotions by habituating to having someone behind them. And this is a really intensive therapy. Eye movement desensitization is one of the evidence-based practices I know less about, and I'm not going to talk a whole lot more about. The problem with all of these is that high functioning is required. If I'm supposed to write an account of what happened to me, write my thoughts, remember to do my in vivo exposure, remember to do all of these things, then one of the things that's going to happen is that I'm going to get disorganized. I might not be able to manage my time. There's a fancy word called alexithymia, which is the idea that I can actually identify what I'm feeling based on what's happening. And many people with TBI, they can't do that. they don't know what they're thinking or feeling. And if you've been in an IPV relationship long enough and have been told what to think and feel, or what you think and feel is wrong, you probably don't know how to do that either. So some of these have a lot of real difficulties. And this is true, especially with our veterans who have the either combat related PTSD brain injury or the IPV brain injury. So VA has two trans diagnostic programs. So you don't have to have PTSD, depression, anything to participate in them. One is called Strength at Home, and this is for the user of intimate partner violence. And it a lot of times is through the Veterans Court. We get referrals and people are required to participate in this. It gives you education, but it also holds you accountable. It can be anywhere from 12 to 26-week group intervention. And then there's also one for couples. Now, I put over here on the side a question of structural inequity, because what I want you to know is that VA has poured millions of dollars into training people, and we have tons of Strength at Home available. What do we have that's equivalent for the experiencer of intimate partner violence? We have a 4-week strengths-based program that is for people who are pretty well out from being in a violent relationship. And it's based on empowerment and social connectedness, and it's got great evidence to support it. However, we know that any successful intervention has to be multi-layered. It has to include emotion regulation skills. It has to address all of the maladaptive coping, like using substance. You know, a lot of our I wanted to say victims, but experiencers of intimate partner violence, they've been exposed to infectious disease, and they are totally influenced by these social determinants of health that are part of structural violence, such as poverty and lack of safe housing. So I know I've run out of time. So these are just some things that I wanted to share with you. And I hope that they have been validating and supportive, and maybe you've gotten 1 or 2 ideas from them. Thank you.
Amazing. We do have some time for questions. Deleene, that was a fantastic presentation. And hearing you put it all together, I can see how I'm saying from a selfish perspective that I've been so grateful to get to spend the last 6 years learning from you. So let's look into the Q&A. Sorry. The first one here, is the RISE program only available to veterans? And is there a similar program for non-veterans?
I don't know that the manual, I know that there are publications about RISE. Kate Iverson at the National Center for PTSD is the person I would ask about that.
Okay. Well,
I very rarely leave the VA, and I don't think about outside the VA very much.
well, Dr. Iverson is on the panel tomorrow morning.
Yay, okay,
So
y'all can ask her.
We can bug her on about that one tomorrow. The next one in here is there a best practice for communicating openness to VA patients so that they do not feel as though they are going against the community they were part of, i.e. the military? For example, some veterans are very proud of their service and may feel a bit of dissonance communicating their issues with the community they are part of for the majority of their adult lives.
Yes. You know, some of our veterans have really high clearance for security classification and things like that. And number one, they're afraid that people in the community aren't going to understand, or they're going to judge them, especially some of our older veterans who were told they were baby killers when they were coming back from Vietnam. They may have some hesitancy. And I always say, I've never been in the military. I do not understand, but I do know how to treat what is going on with you. But I can't do that if you don't talk to me. So I never try to pretend I understand. And I also try to normalize that, you know, part of the losing the identity of the self in the military is the fear of betraying the military. So creating that safe space where I'm not going to document what you said. I know you're afraid that somebody's going to come get your medical records and they're going to put you on trial for something, but that's not going to happen because you're welcome to look at my records. I'm never going to document these things.
Someone is asking for the reference slide. We can send that to people, right?
Yeah, you can send all of it to them.
Yeah, because these will be recorded for everybody who's on here. These will be recorded and you'll be able to access all of these talks within a week or so. We have to get them spliced and uploaded. But we will be able to provide you with that. Okay, just now.
I think another thing going back to that question is that when people look at me, they see, you know, a white woman who they probably assume has privilege. And how could I possibly understand, you know, what they've experienced? And so I try to put that on the table too, you know, just actually owning that I don't understand the intersection of poverty and racism and being in the military or any of those things, but I'm willing to learn. And one of the best things that I can do is to ask people to help me understand.
And I think that perspective is something that I believe we can all learn from, is learning that understanding. The other question we have in here is it possible to get a link for that study Dr. Menefee referenced about the 22% of those experienced MST were knocked unconscious? Fingers crossed. Well,
yes, we're working on it. I'm hoping to get it published in the next couple of months.
Yeah,
it's almost ready.
Okay. I'm just checking. All right, if anybody else has any questions.
Yeah, domestic homicide instead of femicide, yes. I tend to lean into feminism a little bit, so you're absolutely right, and I appreciate that. Thank you.
Awesome. Well, I want to thank our speakers. Tomorrow morning we start again, or tomorrow afternoon Eastern time, morning Pacific time, we start again at noon with a panel on moving forward, or moving IPV brain injury work forward. Again, thank you so much to all of our speakers, our panelists, our moderators, the organizers. We're so grateful and are excited to start this again tomorrow and have you all back. Again, this will be recorded, so if the information went by too quickly, you can get it on the website in around a week. So thank you all. See you tomorrow.